Good afternoon. It's my pleasure to be today to present my case in JS complication meeting. Before I start, I want to thank Dr. Musa Akbar and Dr. Abdullah Shah for inviting me for this meeting. So my case, probably simple case after all these complex cases, it is two perforations, same patient. But what I want to say that when you do a CHIPS case or a high complex case, please just wait, don't declare victory before you be sure that there is no complication. And this is the idea of our presentation today. So my patient was a 65-year-old gentleman. He was diabetic, hypertensive, and he has COPD and dyslipidemia. Admitted in Fujairah Hospital with acute coronary syndrome. He has chest pain, he has ECG changes in inferior leads, and there is marked elevation in the troponin. We did for him echo. The patient actually admitted night, and so echo at the time of the presentation showed only LVH with a preserved ejection fraction, and there is some inferior-basal hypokinesia. So this is the ECG. Doesn't show significant changes apart from some T-wave inversion probably in the inferior leads. Otherwise, not too much significant. So this patient, acute coronary syndrome with the ECG changes and troponin, decided to be taken to the cath lab. Actually, this case done by one of my colleagues in the hospital. So the left system was normal or mild disease. Actually, there is no significant disease, but clearly the calibrate lesion is the both proximal, mid, and even distal RCA. So this is the first shoot, and this is another view. The patient have two significant lesions. So they put a wire, and this is one of probably drawback or mistakes done that time because they inflated the balloon at the proximal lesion, probably because that time they want to do intravascular imaging and the catheter couldn't pass, but they inflated the balloon, and later on they plan to do rotablator. Usually we don't recommend to inflate the lesion if you are planning to do rotablator to avoid dissection. So the balloon inflated the proximal lesion, and they put two wires, and finally they put a pacemaker, and they started rotational atherectomy. So they rotate proximally, and if you look to the wire, look to the movement of the wire, it will be related to our case today. So rotation clearly to the proximal lesion and mid lesion, and the wire was jumping here and there actually during the procedure. The procedure then they did multiple runs of rotational atherectomy, and they put a stent in the mid to distal, then another stent in the proximal portion overlapped with the distal stent, and that was the result. See the wire also, the distal part of the wire, and that was the final result. It's clearly there is nothing. That time the patient developed hypotension during the procedure. Actually, this procedure finished with doing intravascular imaging. The stents where both of them are expanded and opposed, and there is no the dissection distally, and the patient having no chest. No, they changed it. They changed it. So this is the second wire after they finished the rotablator. So this is not a rota wire. And they finished actually after they sure that there is no, the result was quite good. The patient have no chest pain, but the patient have low blood pressure at that time. But they didn't find anything. So they started him on some vasopressor, and they transferred him to the CCU with the vasopressor or inotropic agent. And that was the end of the day. We are having many cases that day. So that was the end of the day. And after a few hours, I was on call. That was post working hours. They called me that the patient who finished the procedure developed cardiac arrest. So CPR started immediately. And after almost 10 to 15 minutes, the patient achieved ROSC. And I came to the hospital. During the way I asked them to do ECG. At the beginning, I thought probably stent thrombosis, but the ECG came only sinus tachycardia without any ST elevation. So when I reached the hospital, I did for him echo, and echo showed the unfortunately large pericardial effusion with tamponade. So at that time, clearly that this patient probably had perforation. I reviewed the last images in the coronary angio done in the morning. There is no perforation actually. So why this patient have such large perforation? So I mean large pericardial effusion. I put in my mind this is probably a perforation, maybe not seen that time. So this is a universal algorithm of coronary perforation. I reviewed it before I took the patient to the cath lab. So we put in our mind that this patient we started on an IV fluid. We started him on, he's already actually on vasopressor. We don't have surgeon actually to notify him. And I planned the pericardiocentesis set, and I took him to the cath lab. Putting in my mind, I might find perforation, but probably proximal perforation, because large amount of effusion causing hypotension. I have covered the stent and I have coiled, and I took the patient to the cath lab. And this is the first part. I put pericardiocentesis, and it drained a large amount of blood actually. And we do, after we aspirated this blood, we did auto transfusion of the blood. Then this is the first injection. It showed a clear large perforation at the proximal part of the RCA. That time I have actually only one access. Patient was hypotensive, not that too much good blood pressure, so I have only one access. So immediately, this is I took the guide catheter, and I put a wire. Yeah, that's why this is actually the title of this presentation. So actually, because the patient was unstable, anesthesia with us, we did many things. So actually, we focused only to the proximal perforation. We focused only on the proximal perforation. We put a wire, then I put a covered stent, and I inflated the stent. Only we focused to the proximal perforation. But if you look to the distal part, actually, as you mentioned, that there is another perforation, the distal artery. That time, the patient is okay, so I try to put a wire. I inflated the balloon proximally, trying to avoid using coils or anything, because I don't know from where it's coming, this perforation. I saw staining, but I don't know from which branch. But because I saw the coronary angio before this time, I suspected that this is the branch that caused perforation. So first of all, I put a wire and balloon, inflated balloon, and unfortunately, still we have the perforation. So I used the fine cross microcatheter, trying to push coils. Unfortunately, the coils stuck at the end of the microcatheter. I tried to push, but I failed. So I pulled the microcatheter with the coil. And after that, I noticed that the distal perforation sealed already. There is some staining proximally. So I just inflated the stent proximally, and the final result was good. Blood pressure, some improvement actually after we finished the procedure. And that time we finished the procedure with, we repeated the echo before we left the cath lab, and there is no more effusion. And we waited for 10-15 minutes to be sure that there is no other perforation, or the distal perforation completely sealed and not recurred again. That was the final result. And the measures we did, auto transfusion, and we give the patient IV fluid and vasopressor, and we kept the patient the CCU echo repeated almost 3-4 times over the night, and there was a complete resolution of the effusion. The blood pressure improved. We started to stop the vasopressor. Unfortunately, because the patient has COPD, actually severe COPD, and he has a quite long course in the ICU, complicated by aspiration pneumonia, and he stayed in the ICU almost 3 weeks, then unfortunately passed away. So the take-home message: complications are common, particularly after complex PCI, and the operator always should have a low threshold to early recognize the complication. And as all you mentioned, that all equipment should be available before starting any CHIPS procedure. Thank you very much.